Hello all, welcome back to my channel. As promised, this is a continuation of MRCP part 1 sample question discussion with detailed explanation for the answers. Okay, question 101. Of a 28-year-old man presented with 1 month history of fever, joint pains and itchy rash that tended to occur in the morning. On examination, temperature was 39. He had swollen warm ankles and wrist, a maculopapular rash on his trunk and leg and splenomegaly. HB is 11, white cell count is 21,000, pretty high, with neutrophilic predominance of 19,500. ESR is high and ferritin is also high. Chest X-rays normal. What is the most likely diagnosis? So a case of fever, joint pain and non-itchy rash, some kind of arthritis. Okay. Again, fever, joint pain, rash could be vasculitis. Fever, joint pain, rash could be your sarcoidosis, but usually the rash in sarcoidosis is called erythema nodosum, which is erythematous seen mainly over the shin. Here it is maculopapular and it is seen on the trunk and legs. There is also splenomegaly. So we'll look at the option. It is adult onset Still's disease, hemochromatosis, Lyme disease, lymphoma, sarcoidosis. So sarcoidosis, again we see chest x-ray, we can see mediastinal lymph nodes. There can be granuloma, okay, can be erythema nodosum. And serum AC is one of the tests that we do for sarcoidosis. Okay, no mention of all of these in here, so unlikely to be sarcoidosis. Lymphoma, again mediastinal lymph node, they can be cervical lymph node. Okay, mainly Hodgkin's. You can have mediastinal lymph node, and there is Ann Arbor staging for the staging of Hodgkin's lymphoma. Lyme disease can present with fever. It can have arthritis. It can have rash, which is called erythema marginatum in Lyme disease. But there can be one peculiar rash that begins in the initial stage and then it persists. But here there is also splenomegaly and ferritin is high, ESR is high, unlikely to be Lyme disease. Hemochromatosis, not likely. Hemochromatosis, you can get bronze diabetes. The skin can be bronze color. Due to the discoloration of the skin, it's called bronze diabetes. They can manifest with diabetes, the liver cirrhosis, other problems, and they can have bronze diabetes. Not the case here. So it is adult onset Still's disease. So adult onset Still's disease, main manifestations are your fever, joint pain, and rash. They can have splenomegaly, they can have high ferritin. Okay. So what are the symptoms? Fever, joint pain, rash, and muscle pain. And other symptoms can include sore throat. They can have abdominal pain. The commonest manifestation is your fatigue. Okay, you can have fatigue also and malaise. So that is adult onset Still's disease. Next question. A 24-year-old woman presented with recurrent joint pains. A range of investigations including a test of autoimmune serology was performed. Anti-nuclear antibodies were detected, but the isotype was not indicated. What anti-nuclear antibody isotype is most likely to indicate a diagnosis of SLE? A direct fact-based question. What is the antibody type found in SLE? Is it A, D, E, G or M? It is IgG. In SLE it is Ig. Next question. An 80-year-old man underwent carotid endarterectomy after an ischemic stroke. Investigation showed carotid plaque histology showing presence of foam cells within the intima. In atherosclerosis, what is the origin of foam cells? Again, fact-based question. What is the origin of foam cell? Foam cells are formed from, foam cells are basically fat-filled macrophages. Macrophages are formed from monocytes. So it is, origin of foam cell is monocytes. Okay, within the intima, there is monocyte which is maturing to form macrophages. Macrophages are then filled with fat and then they form a foam cell. Okay, and then they all the foam cells uh, form a lipid core. Okay, they can then undergo necrosis. Okay, this is in a erythematous plaque. Next question. A 16-year-old boy presented with 9-month history of a right-sided neck swelling which had steadily increased in size over the previous 3 months but had remained painless. He had no other symptoms. On examination, he had enlarged preauricular and jugular digastric lymph nodes and there were no other abnormality. Investigations showing chest X-ray, which is normal. What investigation would be most useful in making a diagnosis? So, a 9-month history of right-sided neck swelling. Okay, which increased in size but no pain. Okay, we also had preauricular and jugular digastric lymph nodes but no other abnormality. Chest X-ray is showing uh, abnormalities. Options are bone marrow examination, CT scan of head and neck, excision biopsy of cervical lymph node, fine needle aspiration of cervical lymph node, Mantoux skin test. So based on the age and the presentation of a lymph node which is gradually increasing, there are also other lymph nodes. Even though chest X-ray being normal, we have to suspect Hodgkin's lymphoma, and the initial and investigation to confirm the diagnosis should be an excision biopsy of the cervical lymph node, suspecting a case of Hodgkin's lymphoma. Next question. 17-year-old girl of Asian Indian descent presented with a typical rash of erythema nodosum over her shin. She felt otherwise well. She had been born in UK and had no previous medical problems. X-ray showed a very abnormal mediastinal silhouette. Serum LDH is 370, serum AC is 78, alpha fetoprotein is 1 kilounit per liter, which is normal, less than 10 is normal. Serum beta HCG is less than 1. CT scan of thorax, 12 cm diameter, complex soft tissue lesion in anterior mediastinum, encasing great vessels in superior mediastinum, enlarged left paracardiac and hilar lymph nodes up to 11 mm in diameter, no further abnormality in thorax or upper abdomen. So, she's having erythema nodosum. Erythema nodosum, you usually suspect sarcoidosis. Okay, and chest X-ray is showing abnormal mediastinal silhouette. But for sarcoidosis, I told you it's serum ACE, one of the investigations for sarcoidosis. But here it is normal. So we'll look for other possibilities. Serum LDH is 370, which is high. Serum LDH is high. Alpha fetoprotein, okay, anything related to the hepatocellular carcinoma and all, but it is normal. Beta HCG can be elevated in a teratoma, but again that is normal. But there is a mediastinal mass with erythema nodosum and raised LDH. We look at the options: Hodgkin's disease, sarcoidosis, teratoma, thymoma, tuberculosis. So again Hodgkin's disease, because LDH is raised, there is mediastinal silhouette and erythema nodosum. Sarcoidosis is not the option because serum AC is not elevated. Teratoma not the option because beta HCG is normal. Not a thymoma. A thymoma is usually associated with myasthenia gravis-like picture. Not tuberculosis. Tuberculosis is usually present with a cavitation lesion in the lung parenchyma with fever, night sweats, and maybe hemoptysis. So this is Hodgkin's disease. Next question, a 20-year-old woman presented with fever, headache and non-blinding rash of 12 hours duration. She was found to have meningococcal meningitis and septicemia and started treatment with appropriate therapy. The consultant in public health medicine was notified and advised prophylactic antibiotics for her close contacts. She shared a house with 3 friends who were all well. What is the most appropriate prophylaxis for her housemates? So according to NICE guidelines for meningococcal meningitis, the contacts should receive ciprofloxacin prophylaxis. Okay, ciprofloxacin. Next question, a 23-year-old woman was referred for further investigation of primary infertility. Her menarche had occurred at the age of 13 and her menstrual cycle varied in length from 24 to 76 days. On examination, her BMI was 33. She had mild facial hirsutism. So a case of primary infertility, she is 23-year-old. Menarche has occurred at a normal age of 13 and menstrual cycle is irregular. She has a high BMI and facial hirsutism. More likely to be a PCOD, right? We look at the investigation. Progesterone, normal. Estradiol, normal. FSH, normal. LH, normal. Prolactin, normal. TSH, normal. Or slightly raised TSH, okay? What mostly diagnosis? Endometriosis usually presents with pain, okay? Non-classical congenital adrenal hyperplasia, but there is no other LH FSH abnormality, and there is she has attained menarche at the right age. She only has regular cycles with hirsutism, high BMI, and primary infertility. So it is most likely polycystic ovarian syndrome. Prolactinoma, the prolactin levels are normal. Subclinical hypothyroidism, she has no other features of hypothyroidism. And the TSH is also normal. So it is polycystic ovarian syndrome, which can have various manifestations like it's a part of a metabolic syndrome. They can have diabetes, they can have excessive body hair growth, hirsutism, they can have trouble conceiving or infertility, they can have weight changes and trouble losing weight. They can have polycystic ovary or ovarian cyst on USG, low sex drive, irregular periods, male pattern baldness and thinning of hair, high testosterone levels. So the hormone imbalance is high testosterone. And they can have insulin resistance and diabetes, fatigue, acne, and mood changes. Next question, a 70-year-old woman presented following sudden onset of painless diplopia. On examination, movements of her left eye were limited in all directions. There was a mild left-sided ptosis. Her left pupil was larger than her right and reacted poorly to right, both direct and consensual. There was loss of pinprick sensation of her right forehead. What is the most likely site of lesion? So we look at the nerves involved. Sudden onset of painless diplopia. Okay, so some of the extraocular muscles are involved. We'll see which all are involved. Movements of her left eye limited in all directions. So all of the extraocular muscles, so all of the 3, 4, 6 nerves are involved. Okay, so we have 3. There is involvement of 4. And there is involvement of 6. That is why she is having diplopia also. There was mild left-sided ptosis also, again due to third nerve. Left pupil was larger than her right. Okay, again due to third nerve, because third nerve is supplying the constrictor pupillae. Reacted poorly to light, both direct and consensual. Third nerve palsy. Loss of pinprick sensation over right forehead. That is fifth nerve. So most likely site of lesion. So 3, 4, 6, they all combine at the cavernous sinus. Okay, cerebellopontine angle, it is usually 7 and 8. Left medulla, no, because the cranial nerves 6 is not coming where 3 and 4 is coming. Okay, 3 and 4 is mainly in the midbrain, and 6 is in the pons. So it is not medulla, it is not midbrain, it's not pons, it's left cavernous sinus. Okay, and it will be ipsilateral. Okay, if there are two options, left cavernous sinus, right cavernous sinus, choose left cavernous sinus because it is like a element lesion. Because the brainstem is where the nucleus is present and the nerves are coming from there and supplying the muscle, so it is an element lesion. It is ipsilateral. Next question, a 60-year-old man was admitted with seizures and altered mental status. He was treated with intravenous acyclovir for suspected viral encephalitis. The product literature advised maintaining adequate hydration to avoid renal injury. What is the mechanism of renal injury with acyclovir? Fact-based question, acyclovir can cause crystalluria, that is why you advise adequate hydration to avoid renal injury with acyclovir. So it is crystalluria. Interstitial nephritis usually happens with NSAIDs and other drugs. Renal ischemia, no. Glomerulonephropathy, no. Acute tubular necrosis, no. It's crystalluria. Next question, a 45-year-old man with trisomy 21 underwent chromosome analysis to provide information about the possibility of recurrence in his family. Chromosome analysis confirmed that his karyotype was 47XY plus 21. What term best describes this karyotype? So, usually there are 23 pairs of chromosome. 23 pairs of chromosome means a total of 46. This patient is having 47 with XY with addition of 21. Okay, we'll see the options: aneuploid, diploid, haploid, monoploid, triploid. Okay. Okay, so there is a question on ploidy. We'll see what each of those means. So ploidy, it could be euploidy or aneuploidy. Euploidy means a set or a multiple of n. Monoploidy means there is only n chromosome. Diploidy means 2 times n chromosome. Polyploidy means more than that. And again, anyway, it is a multiple of n. Aneuploidy means anything less or more than the normal set. Hypoploidy or hyperploidy. If it is hypoploidy, it is less than normal. If it is monosomy, one chromosome is less. So 2n minus 1. 2n is the usual set, which we n in our case, in human case, it's 23. Okay, the number of chromosomes that is seen in a gamete or a haploid set is called n, which is 23 in our case. So anything, if one chromosome is less, it's called monosomy. Anything less than the normal set is called hyperploidy. Monosomy means 2n minus 1. Allosomy means 2n minus 2. A pair is lost. Okay, hyperploidy means more than normal. So trisomy, which is seen in Downs, which is trisomy 21, is a kind of aneuploidy. Okay, it is a kind of aneuploidy. So remember this term, it is a kind of aneuploidy. You will remember trisomy, but you might forget aneuploidy. So it is a kind of aneuploidy. You may also call it hyperploidy. So in the option there is no aneuploidy but hyperploidy, you have to choose that. So trisomy is a kind of hyperploidy, anything more than the normal set. 2n plus 1 is trisomy, tetrasomy is 2n plus 2. Monosomy, trisomy, allosomy, tetrasomy. Okay, remember those terms. Next question. A 65-year-old man with atrial fibrillation which was suboptimally controlled by atenolol was treated with the addition of oral digoxin 250 micrograms daily. His physician explained that the full effect of this treatment would not be apparent for at least a week. On which pharmacokinetic variable did the physician base this explanation? So for digoxin, the half-life is pretty long. It's 36 hours, and for that is why a steady concentration will be attained in our body only by around a week of starting the treatment. So it is due to a prolonged half-life. Okay. Next question, a 45-year-old woman presented with 5-year history of pain in her right hand spreading to the whole arm and the scapular and pectoral areas. On examination, there was wasting of small muscles of her right hand and mild weakness of her right hand and wrist. The right biceps, supinator and triceps reflex were all absent. On sensory examination, there was impairment of pinprick and temperature sensation throughout her right arm. What is the most likely diagnosis? So we'll see what all is affected. Pain in right hand, spreading to whole arm and scapular and pectoral areas. You have any clue of the kind of distribution they're talking about? So pain in the right hand, okay, spreading through whole arm, the scapular and pectoral areas, okay, like this on the right side. On examination, there was wasting of small muscles of right hand, mild weakness of her right hand and wrist. Right bicep, supinator and triceps reflex were all absent. So, wasting of muscles, weakness of right hand and wrist, bicep supinator reflexes are also absent. Sensory examination, there was impairment of pinprick and temperature throughout her right arm. So, pain and temperature, that is spinothalamic tract on the right of her right hand is involved, along with the reflexes are involved, along with wasting of small muscles of the right hand. We look at the options. Cervical spondylosis, how do they present? Cervical spondylosis is usually a neck pain radiating down to the hand. Okay, they usually don't involve the scapular, pectoral areas. There is no wasting. Okay, and the reflexes, pinprick and temperature, it's not a distribution like this. Okay, presentation like this. Malignant infiltration of right brachial plexus. If the brachial plexus alone was involved, they would uh, affect all of the muscles of the hand, arm, forearm. Okay, and they'll be okay, again, all of the reflexes can be absent. There can be wasting, but the pinprick and temperature sensation, which is the spinothalamic tract, they might not be involved, right? Multiple sclerosis. Multiple sclerosis usually is the most common presentation is relapsing remitting. Where there is initial stroke-like manifestation, then there is complete remission, and then they come with presentation in some other part of the body. Okay, not the case here. Subacute combined degeneration of spinal cord. It can affect the posterior cord, which is the dorsal column tract, and the lateral. It's called posterolateral cord syndrome. Not the case here. Syringomyelia. We'll see what syringomyelia is. Syringomyelia is you have your spinal cord, okay, and there is your dorsal horn and the ventral horn, okay, and this patient is having manifestations on the right side, okay, the right side, the right spinothalamic tract is involved. So here, what we need to know about spinothalamic tract is it crosses the same level or 2 or 3 levels above. So when there is impairment of pinprick sensation on her right arm, there is the contralateral side may be affected. Here again, biceps, supinator, triceps reflexes are absent. Okay, that's a areflexia element kind of thing. Okay, ipsilateral wasting. Okay, so the syringomyelia means a cavity is developing from the spinal canal and it is spreading outside. Okay, so this can develop, so that can involve your spinothalamic tract. Okay, when it involves the spinothalamic tract, it can manifest like this. Again, you can have your element kind of weakness and wasting. Okay, so that is syringomyelia. There is a syrinx or a cavity developing within the spinal cord. The spinothalamic tract can get involved and affect pain, temperature, crude touch, and pressure. Then the distribution is classical. It's called cape-like distribution. Both sides can also get affected. That's called a cape-like distribution. Your arm and scapular and pectoral region can be affected. That's called a cape-like distribution. There can be scoliosis and Charcot joints. Okay, in this case there was wasting and loss of reflex. Next question. In a healthy subject, what is most likely to decrease pulmonary vascular resistance? Options are endothelin, epoprostenol, hypocapnia, hypoxia, noradrenaline, or norepinephrine. Endothelin is a vasoconstrictor. It increases vascular resistance. Epoprostenol, prostacyclin, that can reduce vascular resistance. Hypocapnia, hypoxia, they can all increase vascular resistance. Norepinephrine also may increase. So it is epoprostenol or prostacyclin. Next question, a 30-year-old woman complained of hand tremor at a routine transplant clinic review. She had a successful renal transplant 3 weeks previously. Her medication include mycophenolate mofetil, tacrolimus, prednisolone, cotrimoxazole, and Valgia and cyclovir. Which drug is most likely to be the cause of a tremor? So, mycophenolate mofetil, tacrolimus, prednisolone is for immunosuppression, cotrimoxazole is for PCP prophylaxis, Valtine cyclovir is for CMV prophylaxis. So, what is the likely cause of a tremor? So, this one is tacrolimus. It is one of the commonest side effect of tacrolimus, and the patient should be educated that while you are starting on tacrolimus, you can have tremor. Next question, a 26-year-old woman with a previous history of deep venous thrombosis was treated with low molecular weight heparin for a further episode proven by a Doppler ultrasound scan. She also reported that she had two first trimester spontaneous miscarriages. She was currently using contraception. Investigation PT is 13, HPTT is 52nd, slightly elevated. Anticardiolipin is 62 elevated. Pregnancy test is negative. So it is a case of clear-cut case of APLA. Recurrent miscarriages, the APLA antibodies, one of which is anticardiolipin is elevated. There can be isolated APTT elevation in uh, APLA, antiphospholipid antibody syndrome. So what is the most appropriate treatment? So you have to give anticoagulation. So the choice is dabigatran. She is currently using contraception, but if she is planning on pregnancy or is found to be pregnant, you have to switch back to low molecular weight heparin. You don't give warfarin in this uh, if she has a possibility of becoming pregnant. Usually, warfarin is not given. So dabigatran is the choice. Next question. A 62-year-old woman presented with 1 hour history of left-sided weakness. She was found to have an ischemic stroke. A decision was made to administer alteplase. What best describes the mechanism of action of alteplase? Options are acceleration of plasminogen to plasmin conversion, ADP receptor antagonism or P2Y12 receptor antagonism, cyclooxygenase 1 inhibition, factor 10A inhibition, vitamin K epoxide reductase inhibition. So it is acceleration of plasminogen to plasmin because alteplase is given for thrombolysis. So what is happening during thrombolysis? Plasminogen is converted to plasmin and their thrombus is lysed. Which are the drugs which is P2Y12 receptor antagonist? They are clopidogrel and ticagrelor, which is COX inhibitor. That is your selective COX inhibitors. Or NSAIDs. They are COX inhibitors. Factor 10A inhibition. Factor 10A inhibitors, apixaban. Vitamin K epoxide reductase inhibition is warfarin. So this case, it is plasminogen to plasmin conversion by alteplase. So in thrombolysis, plasminogen is converted to plasmin and they degrade the fibrin into fibrin degradation products, one of which is D-dimer. Okay, so here alteplase is accelerating this conversion. Next question, a 70-year-old woman presented after being found collapsed at home. Examination showed weakness of lower two-thirds of left side of her face and a dense left hemiparesis affecting her arm and leg. So lower two-thirds of left side of face. Weakness of lower two-thirds of left side of face. That means a human kind of facial palsy with dense left hemiparesis. She had a fixed gaze palsy to the right affecting both eyes, damage to which area of brain is most likely to have reduced the gaze palsy. Left frontal lobe, left medulla oblongata, left occipital lobe, right frontal lobe, right occipital lobe. So it's a UMN palsy in the facial nerve with the dense left hemiparesis. So it is the brainstem lesions are usually crow's lesions. So cranial nerve will be one side and hemiplegia will be on the opposite side. So it's not medulla oblongata. not a brainstem lesion. Occipital lobe usually manifest with a visual defect and all. Frontal, is it a right frontal or left frontal? Okay, that is the question. It's a right frontal or left frontal. Hemiparesis, they always comes contralaterally. So it is a right frontal lobe because the fibers from the cortical radiation and all is coming only in the medulla. The pyramidal decussation is it decussating and forming the lateral uh, corticospinal tract. So it is always contralateral. So there is dense left hemiparesis. So it is a right frontal lobe. And in frontal lobe lesion, there is gaze palsy to the and the patient looks to the side of lesion. That is why in a right frontal lobe there is gaze palsy to the right. Next question: a 55-year-old man presented saying that he had coughed up blood on several occasions. Investigation showed a squamous cell carcinoma of lung. What associated finding is a contraindication to surgical resection? So, patient having hemoptysis, investigation is showed he's having a squamous cell cancer. So, resection is contraindicated in a case of distant metastasis or superior vena cava obstruction. Okay, superior vena cava obstruction. This hypertrophic pulmonary osteoarthropathy, hypercalcemia, and all is a uh, again finger clubbing and hypertrophic osteoarthropathy is same. It is one of the severe form of clubbing. Okay, they are all paraneoplastic. Even if it is present with resection, they may improve. But with superior vena cava obstruction, it may be unlikely that the patient may benefit with resection. So it is SPCO. Next question: a 78-year-old man presented with 3-month history of hematuria, increasing tiredness and breathlessness on exertion. On examination, he looked pale. So hematuria, tiredness, an elderly man, and breathlessness on exertion. HB is low, MC is high. Okay, low HB, MCV is high, 108. Okay, white cell count 2.6 into 10 raised to 9 or 2600. Neutrophil 900. Platelet is 78,000. So there is low platelet. Okay, and white cell count is low. And blood film is showing nucleated red blood cells. So there is production in the bone marrow, myelocytes and metamyelocytes, and a left shift of the neutrophils. So there are precursor cells. Precursor cells are immature cells in the myelocyte series, and nucleated red blood cells, which is also again immature RBC. So there is production in the bone marrow with high MCV, and the patient is 78-year-old with hematuria. Okay, so it could be some kind of a metastasis in an elderly with hematuria coming with a picture like this. We'll see. What is the most likely cause of abnormal blood film? Aplastic anemia? No. In aplastic anemia, all of the production will be low, so you can't see nucleated RBCs and myelocytes and metamyelocytes. So it is not aplastic anemia. Bone marrow metastasis can be a case because it is a case of hematuria. Patient may have a bladder cancer and may have metastasized to bone marrow, and this picture is called leukoerythroblastic kind of picture. And hypothyroidism, not likely. Myelodysplasia, no. Vitamin B12 deficiency, no. That cannot explain the myelocytes and metamyelocytes. Okay. In vitamin B12, you usually have a hypersegmented neutrophil. Okay. So it is bone marrow metastasis. This is called a leukoerythroblastic picture. Both there is erythroblast, that is immature RBCs, and immature neutrophils or left shift of neutrophils. Next question: a 23-year-old man was admitted with a 3-day history of lower cramping, abdominal pain, and fever. He had mild diarrhea but no blood in stool. He had no travel recently. So lower cramping, abdominal pain, 23-year-old. Only diarrhea, no blood, no travel history. He was tender in right iliac fossa. There were raised tender red nodules on shin. That can be erythemanodes. CT showed cluster of lymph nodes at appendix suggestive of mesenteric adenitis. What is the most likely cause of symptoms? Campylobacter jejuni. Campylobacter jejuni can cause diarrhea. Uh, Usually the complication is GBS. So in Campylobacter jejuni, the complication is GBS. Salmonella enteritis. Tuberculosis. Tuberculosis? No. Ulcerative colitis. Here, this is the classic CT scan showing cluster of lymph nodes at appendix, suggestive of mesenteric adenitis. Now, this is classical of this Yersinia enterocolitica infection. Ulcerative colitis can also have your shin lesions, but that is pyoderma gangrenosum, not a raised red nodule. That is erythema nodosum. Erythema nodosum you can see in sarcoidosis and other conditions. In this case, Yersinia. But ulcerative, you get ulcer like thing. That is pyoderma gangrenosum. Okay. TB not present like this, not also salmonella. Salmonella can have also blood in stool. Okay. Here there is no blood in stool, but there is mesenteric adenitis, Yersinia enterocolitica infection. Okay, that's all for today.